So complication of sinusitis may be local, locoregional and distant complications. Local complications, that is inside the nose and paranasal sinuses, that is mucocele, mucopyoceal, mucus retention cyst, osteomyelitis of the bones of the sinuses, that is more common in frontal bone and maxilla. These are the local complications. Locoregional complication includes the structures surrounding the nose and paranasal sinuses, that are orbit and intracranial structures. In orbital complications, we divide this complication into preseptal complication and postseptal complication. Preseptal includes the inflammatory edema of the ribs. Then postseptal means we have subperiosteal abscess, orbital abscess, superior orbital fissure syndrome and orbital A-bit syndrome. Second locoregional complication will be in intracranial cavity. First of all, erosion of the bone leading to inflammation of the meninges called meningitis. Then there can be formation of extradural abscess, then subdural abscess, then brain abscess. There may be cavernous sinus thrombosis. The third locoregional complication is the descending infection from the nose and paranasal sinuses. Descending infection includes all the lower respiratory tracts such as laryngitis, tracheitis, and pneumonia and abscess in the neck, abscess in the lungs. These are the infections of the descending infections due to nose and paranasal sinuses infections. Then third category is focal infections. Infection inside the nose and sinuses can act as focus of the infection. So there may be distant infections such as there may be rheumatoid, there may be infective arthritis, there may be osteomyelitis of some bone, there may be infection of the limbs bone, there may be infection of the bones of the skull, or there may be infection of the one of the joint. Infective arthritis is the descending, is the distant complication of rhinosinusitis. Another important structure that can be involved in locoregional complication is the ear. The infection from the nose and sinuses can go into the ear, leading to the acute suppurative otitis media or chronic suppurative otitis media. So these infection of the nose and paranasal sinuses can involve the ear as well. So now, what are the channels of spread? What are the routes of spread of these infections? First is direct extension. This infection can cause erosion of the bone, such as usually seen in fungal sinusitis, mucormycosis, or in acute sinusitis that will cause erosion of the bone due to hyperemia of the bone. So there will be osteoclast activity, and there will be absorption of the bone, leading to spread of this infection in the locoregional structures. Then in the intracranial cavity, infection can spread through some patent bony sutures, or some previous injury. Can be there can be some open fracture leading to spread of this infection. Then natural foramina such as infraorbital foramina, superior orbital fissure, or orbital apex. Through these natural foramina, infection can spread to the intracranial cavity. Then there is vascular spread through veins, or such as seen in cases of nasal infections. Infection can spread to the intracranial cavity inside the cavernous sinus. So these are the channels of spread of infection. Now we will discuss all these complications one by one. First complication is mucocele and mucopyoceal. Mucocele is due to obstruction of the ostia of the sinus, and it is usually seen in frontal sinus and sometimes in the maxillary sinus. Due to obstruction of the ostia, a whole sinus gets enlarged, and due to this enlargement there will be retention of the mucus and there will be cystic dilatation. It will cause pressure over the lining of the sinus, that is of the bone, so there will be thinning of the bone, and during palpation this thinning can be palpated as eggshell crackling sounds. So due to enlargement it can also displace the eyeball downwards and laterally, so there may be diplopia, sometimes there may be proptosis, there may be headache due to pressure over the nerves, and usually it is diagnosed clinically and also with the help of radiological examination. You will see haziness and mucus secretions inside the frontal sinus, and the best diagnosis is usually made with the help of CT scan. So then after diagnosis there will be treatment. Treatment is usually drainage. So best treatment is endoscopic sinus surgery. With the help of this endoscopes we drain the frontal sinus as well as ethmoid sinus. If endoscopes are not available, then external frontoethmoidectomy is done to drain the sinus. Mucocele of sphenoid sinus is very dangerous because lateral to the sphenoid sinus there are important nerves, so it can cause pressure over the optic nerves and as well as pressure over the third, fourth, fifth and sixth cranial nerve. It can cause paralysis of all these nerves. So sphenoid sinus mucocele should be drained immediately to prevent this pressure over the nerves, and it is done, we will do sphenoethmoidectomy with the help of endoscopes. So endoscopic sinus surgery is the best for this. Otherwise open frontoethmoidectomy with sphenoethmoidectomy is very extensive surgery. So sometimes this mucocele of frontal sinus or sphenoid sinus gets infected, so we will call this mucocele mucopyocele, that is infected mucocele. So if the patient will present with fever and all other symptoms of mucocele, and if there is fever, high grade fever, you will treat the infection with the help of antibiotics, then you will perform surgery. Then mucus retention cyst. Mucus retention cyst is due to blockage of the duct of one of the gland. So difference between mucocele and mucus retention cyst is that in mucocele there is enlargement of whole sinus. There is collection of mucus inside the sinus due to obstruction of the ostia of the sinus. But mucus retention cyst is due to blockage of one of the gland. So usually it is incidental finding on radiograph, and if it is small and asymptomatic, no treatment is required, and cause may be some complication of the surgery and may be due to some chronic sinusitis. But if it is causing pressure symptoms, so it should be treated with the help of endoscopes. Then osteomyelitis of the bone. It is usually seen in maxillary sinus and the frontal sinus. Maxillary sinus osteomyelitis is usually seen with the dental infection. Dental infection can spread to the maxillary sinus involving the bone of the maxillary sinus. So there will be pus collection underneath the soft tissue of the cheek. So patient may have fever, pain over the cheek. Treatment is again antibiotic and drainage. Then osteomyelitis of the frontal bone, when there is osteomyelitis of anterior plate of frontal sinus, the pus or abscess will appear beneath the skin and soft tissue of the forehead. So the patient will present with pain and swelling in the frontal region, and also there will be fever. And whenever there is osteomyelitis of the posterior plate of the frontal bone, infection will go intracranially, and it will involve all the intracranial structures. Treatment again will be antibiotic and drainage of the abscess and sinuses. That is usually best with the help of endoscopic sinus surgery. If not available, then external front-to ethmoidectomy and removal of all the abscess and any destructive bone can be removed. Now we come to the orbital complications. Inflammation and edema of the eyelids, because eyelids are attached to the bony orbit with the help of very thick fibrous band. So it is the first indication that infection is spreading to the eyeball. So it is not very dangerous, but we have treatment should be we should start the treatment immediately, and it is there is only the swelling. Patient will not feel any pain, but it may be due to blockage of the vessels, blockage of the veins draining the eyelids. So there are certain points. If there is swelling of the upper eyelid, that is usually seen in frontal sinusitis. If swelling of the lower eyelid, that is usually seen in maxillary sinusitis. And if both eyelids are swollen, that is due to ethmoiditis. And fronto ethmoiditis is usually seen together. Second complication is subperiosteal abscess. The periosteum lining the nasal cavity gets eroded, and the pus appears in the orbital cavity. But the periosteum lining the orbital cavity remains intact. So there will be actual infection is not entering into the eyeball, but due to this subperiosteal abscess, it can displace the eyeball. So there may be diplopia, pain, fever. The next complication is orbital cellulitis. Now infection breaks the periosteum of the orbital cavity. So it is actually entering into the orbital cavity. First of all, it will cause infection in the orbital fat surrounding the eyeball. Then it will cause spasm of the extraocular muscle. So there will be diplopia and pain during when we will check the movement of the extraocular muscles. There will be spasm, and patient will feel lot of pain. Exophthalmos, there will be protrusion of the eyeball. The edema is present behind the eyeball, so it will push the eyeball forward. And chemosis or conjunctiva. Chemosis means there will be red spots will be seen in the conjunctiva, and the movements of the eyeball will be restricted because there will be spasm of the extraocular muscles. Now, how will you diagnose this case? Based on history, clinical examination, and best diagnosis then will be made with the help of CT scan. Now, fourth complication is orbital abscess. It means actual pus is forming inside the orbital cavity. That is very dangerous condition. It will destroy the eyeball and destroy the vision. So the actual pus formation inside the eyeball will cause complete ophthalmoplegia. There will be no movement, no vision in the eyeball. So diagnosis is best made by clinical examination, history, and then CT scan. CT scan will show the lesion. There will be destruction of the bone between eyeball and nose, and there will be collection of the pus inside the eyeball. So treatment again, antibiotic, eye consultation, and drainage of the abscess, maybe with the help of endoscopes. And you can also take advice from ophthalmologist, and as well as there will be treatment of the sinus should be drained as well. Now, important complications are superior orbital fissure syndrome and orbital apex syndrome. There are, because fifth nerve, maxillary division of the fifth nerve and optic nerve, these pass through the orbital apex. So we will differentiate it from superior orbital fissure syndrome. In superior orbital fissure syndrome, there will be involvement of the third, fourth, and sixth cranial nerve. But in orbital apex syndrome, there will be involvement of third, fourth, sixth, along with the involvement of the maxillary division of the fifth nerve and the optic nerve. Now we come to the intracranial complications. These are the same as we have seen in intracranial complication of the ear infections: meningitis, extradural abscess, subdural abscess, encephalitis, brain abscess, and cavernous sinus thrombosis. So we will discuss in this lecture only the cavernous sinus thrombosis. So cavernous sinus thrombosis is the life-threatening condition. Causes of cavernous sinus thrombosis is nose and sinus infection, boil in the nose, infection of the upper eyelid, ear infections, and acute tonsillitis. In cases of boil of the nose and upper eyelid, because these veins are valvulous, so infection can transfer retrograde and can enter into the intracranial cavity involving the cavernous sinus. So there will be cavernous sinus thrombosis. So cavernous sinus thrombosis, that is the life-threatening condition. It is diagnosed clinically. There will be swollen eyelids, chemosis of conjunctiva, and there will be proptosis. Third, fourth, fifth, sixth cranial nerves will be involved, and there will be pain along with the distribution of ophthalmic division of the fifth nerve. There will be complete ophthalmoplegia. There will be no movement of the eyeball because these muscles are paralyzed, and pupil will be dilated because of involvement of the third cranial nerve. There will be decrease in vision because of involvement of the optic nerve. And really it is how will you differentiate from orbital cellulitis and cavernous sinus thrombosis? There will be bilateral involvement seen in cavernous sinus thrombosis. So CT scan is the best to diagnose all these things, and if you are suspecting cavernous sinus thrombosis, you can also advise MRI. Treatment, because it is life-threatening condition, neurosurgical opinion should be taken, and drainage of the sinus along with antibiotic and neurosurgical treatment should be given. This is cavernous sinus thrombosis, chemosis of the eyelid, proptosis, swollen eyelids, and complete ophthalmoplegia. It is the initial stage. Later on, other eyeball will be involved in this condition. You can also see dilatation of the pupil in this condition. Then descending and ascending infection due to rhinosinusitis. These can involve pharynx causing pharyngitis, tonsils causing tonsillitis, then laryngitis and bronchitis. There may be formation of lung abscesses in cases of infection of the nose and paranasal sinuses. Then infection can go into the ear through eustachian tube, causing acute and chronic infection. Then there are distant infection. This sinus infection can act as the focus of the infection. So there may be polyarthritis, skin infection, multiple boil involving the whole body, and there may be infection of the kidney, and there may also be endocarditis. So these are the distant infection. because sinus infection can act as the focus for this infection. So important point in this scenario is that whenever you are getting scenario and you are thinking that it is related to complications of sinusitis, so don't write any specific diagnosis, only write there is orbital complication of sinusitis. That is probable diagnosis is acute or chronic sinusitis with orbital complication or with intracranial complication, with distant complication. So in this scenario, patient is presenting with high grade fever. It means it is acute condition and there are swollen eyelids. So there is orbital complication of the sinusitis.